Raynaud's phenomenon was first described by Maurice Raynaud in 1862. It is an exaggeration of normal physiological response, and it is defined as episodic pallor or cyanosis of fingers. It's caused by vasoconstriction of small digital arteries or arterioles in response to cold or emotional stress. The main hallmark of Raynaud's phenomenon is change in skin temperature and color on exposure to cold. It is mainly characterized by sudden onset of pallor, and then cyanosis follows due to static blood in capillaries when it becomes desaturated, and then followed by post-ischemic vasodilatation, leading to redness and hyperemia of skin. Occasionally, toes can also be affected in addition to fingers. Initially, there used to be terminology like Raynaud's disease and Raynaud's phenomenon. Now there is only term Raynaud's phenomenon, which is divided into primary and secondary. Primary Raynaud's phenomenon is the most common and idiopathic form. It's a benign process and is not associated with structural vascular change. Secondary Raynaud's phenomenon, it is associated with an underlying disease process like connective tissue disorders, systemic sclerosis, rheumatoid arthritis. And in this, they have some degree of fixed vascular obstruction to blood flow. So this decreases the threshold for cold-induced vasospasm. Epidemiology, it is more common in populations in colder climates, and prevalence is usually seen in general population from the range is from 3.3 to 22%. Risk factors, women are more commonly affected than men. No association was found between smoking and Raynaud's syndrome in women, but there's some association found between smoking and men. Alcohol is also one of the risk factors, and it is more commonly seen in persons in occupations using vibrating tools. It is also seen in persons on using drugs like vinblastine, bleomycin, bromocriptine, amphetamine, cocaine, and ergot preparations. This is the anatomy of hand. The main supply to digits comes from radial artery and ulnar artery, which form superficial palmar arch and deep palmar arch. Each digit gets its supply from superficial palmar arch. Severe digital ischemia can occur with occlusion of either of these arteries, and most commonly seen in persons with incomplete superficial arch. The superficial arch is incomplete in nearly 21.5% of people, and in at least 86% of extremities. All these 5 digits are supplied by arteries from both deep and superficial arches. This is a picture showing Raynaud's phenomenon. Initial stage is pallor and followed by cyanosis. Regulation of blood flow in digits, it's highly variable and it ranges from 1 ml per minute to 180 ml per minute. Blood flow to this skin of digits mostly helps in nutritional thermoregulatory functions and mostly thermoregulatory mechanisms by controlling the body temperature. Usually blood vessels in tips of the fingers that dilate to radiate excess heat from the body, whereas in cold temperatures, this constrict to preserve body heat, and maximum vasoconstriction in response to cold occurs at 10 to 20 degrees centigrade. And at further lower temperatures, there will be regular rhythmic fluctuation in fingers with slightly reopening and constriction of arterioles, and it occurs every 30 seconds to 2 minutes with a frequency of 5 to 10 per minute. And this is called hunting response. In patients with secondary Raynaud's phenomenon, this is impaired. Coming to pathogenesis, exact pathogenesis is unknown. Initially, Raynaud's proposed a theory that it might be due to hyperactivity of sympathetic nervous system, but Lewis in 1929 disproved this theory by demonstrating that blockage of digital nerves did not prevent vasospasm, and he proved that it is due to a local vascular fault in the digital arteries, which causing increased sensitivity of blood vessels to cold. It is mostly multifactorial, and it is due to vascular, humoral, and humoral factors. Main factors affecting are due to nitric oxide, which is a potent vasodilator, and endothelin 1, which is vasoconstrictor. This nitric oxide is synthesized in endothelium, and it is diffused into the media, causing smooth muscle relaxation and further vasodilatation. And endothelin 1 is antagonist of nitric oxide, and it has antagonistic effects with nitric oxide. And alpha 2 receptor, when exposed to cold environment, there is increased sensitivity of sympathetic nerves, and there is release of norepinephrine, and alpha 2 receptors are more sensitized, which results in smooth muscle contraction and vasoconstriction. And the primary Raynaud's phenomenon, it might be due to insufficient nitric oxide, increased endothelin 1, decreased descending pressure, and platelets also get activated, which release 5-hydroxytryptamine and thromboxane A2. These are the conditions associated with secondary Raynaud's phenomenon. It might be due to connective tissue diseases. Scleroderma is the most common one, and might be due to occlusive arterial diseases and occupational arterial diseases like hypothenur Hammer syndrome, and it might be due to vibration-induced one. And drugs, ergot preparations, cocaine, amphetamines, vinblastine, and bleomycin. Also seen in people with myeloproliferative and hematological disease, malignancies, and infections. Clinical findings, typically the attacks of pallor it might involve one or more fingers when exposed to cold, and these episodes are self-limited, may last from less than a minute and not more than 10 to 20 minutes in primary. And thumbs are usually spared in primary. When thumbs are involved, it reaches a diagnosis of secondary Raynaud's phenomenon. These attacks may occur several times a day to several times a week. In addition, these episodes of vasospasm, these are more common in cooler winter months. Pain is usually not a feature, and pain is usually associated in secondary Raynaud's phenomenon because of underlying occlusive disease. Diagnosis, these are the list of criteria which differentiates primary from secondary Raynaud's phenomenon. In primary, the vasospastic attacks are precipitated by cold or emotional stress, and the attacks involve both hands. It might be asymmetric, and there is absence of tissue necrosis or gangrene. There is no history or physical findings suggestive of any secondary cause. Normal nail fold capillaries on microscopy, and negative for serological findings like antinuclear antibodies. While on physical examination, we need to examine large, medium, and small vessels, pulsations to rule out any occlusive disease, and need to observe for any signs of connective tissue disorders, like in persons with connective tissue disorders, hands and there will be tightening, sclerodactyly, or telangiectasia, or any ulceration or hyperkeratosis in tips of hands and fingers. And vascular laboratory evaluation, non-invasive measuring the room temperature of arm, hand, and distal arterial perfusion, and segmental pressure measurements. These pneumatic cuffs are placed on the brachial, upper elbow, wrist level, and systolic blood pressure is measured. The pressure difference exceeding 10 millimeter of mercury, it may be significant and indicative of proximal occlusive disease. Doppler ultrasonography is not of much importance in detecting and diagnosing it, but it has a role. But Lee and colleagues, using power Doppler with 10 megahertz scan, focused at 5 mm with needlefold capillaroscopy for the diagnosis of primary and secondary. Other investigation is finger systolic blood pressure. These are measured by applying small distal cuffs to the proximal part of the fingers. The cuff is inflated above systolic blood pressure to occlude the distal artery, and the cuff is slowly deflated. A difference of more than 15 millimeter mercury between fingers or an absolute finger systolic blood pressure of less than 70 millimeter mercury is indicative of an occlusive disease. Helps in diagnosing secondary Raynaud's phenomenon. World challenging test. It was the first laboratory test used widely for the objective diagnosis of Raynaud's phenomenon. The initial temperature of fingers is measured, and then after dipping the hands, immersing in cold water at 4 degrees for 20 seconds, again the hands are dried and the temperature is measured. The length of time that it takes for the hands to rewarm is normal in normal persons, but in persons with Raynaud's phenomenon, it is increased and typically takes more than 10 minutes or sometimes 30 minutes. It's 100% specific but not sensitive, so it's neither sufficiently accurate or reproducible for clinical use. The non-invasive test is nail fold capillary microscopy. This is done using a microscope or an ophthalmoscope at 40 diopters by applying a drop of immersion oil over the cuticle of the finger to make it translucent. Abnormal capillaries are seen in scleroderma and with connective tissue disorders as enlarged torches and deformed or loop dropout causing avascular areas. This is seen in secondary Raynaud's phenomenon. Serological evaluation in persons with connective tissue disorders, we can routinely screen for rheumatoid factor, anti-nuclear antibodies. Treatment strategies, it includes preventive measures, behavioral therapies, pharmacological therapies, surgical and alternative therapies. In preventive measures, these are simple measures to maintain warmth and avoid cold. These are effective. Ceramic impregnated gloves are much more effective than normal cotton gloves because they absorb infrared light and keep hands warm. Avoiding agents that cause vasoconstriction such as nicotine and vasoconstricting medications is also an important aspect of therapy. Behavioral therapies, it's a type of mind or body therapy which helps in getting exposed to cold environments. Pharmacological therapy is indicated in patients who have failed conservative therapy or simple behavioral therapies. The goal is to decrease frequency and severity of attacks rather than cure the underlying disease. Secondary Raynaud's phenomenon, they often have fixed obstructive disease, and this vasodilatus is less effective. And significant placebo effect is seen in and published in clinical trials, which ranging from 20 to 40. First-line drugs are calcium channel blockers, and these remain the first-line therapy for treatment. Nifedipine is the drug of choice. There was a multi-center randomized control trial conducted in 313 patients with primary Raynaud's phenomenon treated with sustained release nifedipine and compared with placebo, showing a 66% reduction in frequency of attacks. Drugs in dihydropyridine class are more potent vasodilators than non-dihydropyridine class, but they are more frequently associated with side effects. Alpha adrenergic blockers. Sympathetic nerve stimulation, it causes more release in norepinephrine, and which acts on alpha-1 receptor located on vascular smooth muscle, and that's causing vasoconstriction. So this action is completely inhibited by alpha-1 selective blockers. Prazosin is a selective alpha-1 adrenergic antagonist. It significantly reduces the number of attacks in both primary and secondary Raynaud's phenomenon. A double-blind placebo-controlled crossover study was conducted in 24 patients, and prazosin was reported superior to placebo in the treatment of Raynaud's phenomenon. And other alpha-2 antagonists have also been used, like OPC 28326, but more recently ORM 1741 and alpha-2C adrenoreceptor antagonist was found to increase skin temperature recovery time. Other group of drugs are prostaglandins and analogs. Prostacyclins are vasodilators that have been used to treat critical digital ischemia, secondary to fixed occlusive disease. Loprost is a prostacyclin analog which is reported to reduce severity, frequency, and duration of Raynaud's phenomenon attacks and promote healing of ischemic ulcers. Intravenous iloprost was directly compared with oral nifedipine in two randomized controlled trials. Although the medication regime differed, both showed reduced mean number, duration, and severity of attacks and improved ulcer healing. Phosphodiesterase inhibitors. These are selective inhibitors, cyclic guanylyl monophosphate specific PDE5, which increase cyclic guanylyl monophosphate, resulting in enhanced dependent micro and macrovascular dilatation. Sildenafil 50 milligram twice daily. It is proved to reduce the frequency of Raynaud's phenomenon attacks. Tadalafil has been shown to be efficacious in case series, but is not effective as sildenafil. Other group of drugs are endothelin inhibitors. It's a potent endogenous vasoconstrictor. Bosentan is an endothelin receptor antagonist currently used to treat pulmonary hypertension. In RAPIDS-2 trial, bosentan was shown to significantly decrease the incidence of new distal ulcers in patients with scleroderma, although there was no change in rates of ulcer healing or in pain or in disability. Other medications other than these are nitrates like glyceryl trinitrile, but they are not first-line therapy and they are limited by side effects, particularly headaches and hypotension. Other group of drugs are ACE inhibitors like captopril, angiotensin 2 receptor blockers, losartan. It was found to be more effective than nifedipine in reducing the frequency and severity of vasospastic episodes. And this was proved in a randomized controlled trial in patients with primary Raynaud's phenomenon and those with secondary Raynaud's phenomenon due to systemic sclerosis. Fluoxetine and SSRI was shown to reduce the frequency severity of attacks in both primary and secondary. Surgical therapy. Surgical intervention, it tends to be reserved for patients who have failed conservative and pharmacological therapy. Surgical therapies include botulinum toxin injection, sympathetic block, thoracoscopic sympathectomy, digital sympathectomy, and spinal cord stimulator. Other surgical therapies are local debridement of dead tissue or removing of fingernail. Partial or complete phalangoectomy may be sometimes necessary in 10 to 20% of patients with digital ulcers or gangrene. When botulinum toxin was used, it improved pain and ulcer healing in small case series. Sympathectomy, it is rarely useful in primary Raynaud's phenomenon. Recurrence rates are high. It might be effective in some patients who have critical ischemia of the digits. Thoracoscopic sympathectomy has supplanted open cervicothoracic sympathectomy as a technique of choice now. Lumbar sympathectomy can be performed in patients who lower limbs are affected. Adventitial stripping of hand and distal arteries, it has been successful in healing ulcers and improving ischemic pain. Botulinum toxin is a commonly used medication and it primarily inhibits muscle contraction. This toxin is injected into interstitial space around the distal neurovascular bundles, causing chemical sympathectomy. It reduces pain, promotes ulcer healing, and increases blood flow. Nerve stimulation, transcutaneous nerve stimulation, it has been used in some patients to induce vasodilatation. In addition, spinal cord stimulators are occasionally indicated for the treatment of various intractable pain syndromes of the upper extremities. It might help in reducing pain and promote ulcer healing in severe cases of secondary Raynaud's phenomenon. The alternative therapies are acupuncture, and the main mechanism of action is stimulation of sensory nerves, so it causes release of vasodilators and substance P and calcitonin gene-related peptide. Fish oil and arginine have also been investigated. Laser therapies is now being investigated as a potential treatment for a variety of vascular and rheumatological disorders. And the more recent laser therapy is multi-wave log system laser therapy. It improves microvascular changes in nanefold video capillaroscopy, and it also helps in release of circulating modulators like vascular endothelial growth factor and angiopoietin 2. All patients with Raynaud's phenomenon received multi-wave log system laser radiation for 3 weeks. And after 3 weeks, these patients were reported a decrease in the number, mean duration, and pain intensity of attacks. Thank you.